Can everybody hear me okay? Good evening. Welcome to this very special Grand Rounds presentation from our distinguished guest, Dr. Carlo DiClemente, co-creator of the massively influential Transtheoretical Model of Change. My name is Keith Zulig, and I'm with the WVU School of Public Health. School of Public Health is honored and pleased to host and co-sponsor Dr. DiClemente's presentation, along with the Institute for Community and Rural Health, West Virginia Hope and Action Alliance, and Copeland Health Systems. Just a little bit of housekeeping before I introduce our next guest, who will then introduce Dr. DiClemente, is for those of you that are attending online, if and when you have a question, if you could please submit it in the chat, and then we'll read your question out loud when we get to Q&A. Next, I'd like to introduce Ms. Sarah Barton, who was instrumental in supporting this effort. And Sarah is the owner of Profuse Solutions, a consulting agency for nonprofit organizations. She supports organizations in developing strategic plans for organizational projects, sustainability, and fundraising. Ms. Barton has over 20 years of experience working with nonprofit organizations and has formerly served as Senior Project Director at Copeland Health Systems, Senior Analyst for Ethos Leadership Group, Director of Advancement at Ohio Valley University, and as Executive Director of Marion County Foundation. Sarah earned her Master's of Public Administration through West Virginia University. Way to go, Mountaineers go first. And is passionate about wellness and supporting all individuals to their paths to wellness. So welcome. Thank you very much.
Thank you. I'm very excited to be with you tonight. I am from Copeland Health Systems. We work in the Wood, Wirt, and Jackson County area. We're an FQHC, and I have been partnered with Amy Snodgrass through the Rural Community Opioid Response Program grants. We have 2 of them. I have one that serves adolescents, and we provide treatment and prevention efforts for adolescents in Wirt and Jackson counties. And then she has one that works with adults in a seven county area. So we got started in this work 3 or 4 years ago. We developed a program, or Amy really was instrumental in helping adopt a program called Regrounding Our Response. And Regrounding Our Response is a stigma reduction training program. And our goal is to train trainers around the state to address the stigma that prevents individuals from getting the help that they need, and to support the helpers and help them understand what's happening in our communities and how they can better support their communities. And so this week we are training 40 individuals here in Morgantown to be new trainers. And Dr. DiClemente was instrumental in the curriculum related to stages of change. And so we're really excited that he's here with us today. Dr. DiClemente is an emeritus professor of psychology at the University of Maryland, Baltimore County, and director of several training centers at UMBC. He is co-developer of the Transtheoretical Model of Behavioral Change and author of numerous scientific publications on motivation and behavior change with a variety of health and addictive behaviors. He published in 2018 the second edition of Addiction and Change: How Addictions Develop and Addiction People Recover. He has also co-authored several professional books: The Transtheoretical Model, Substance Abuse Treatment and the Stages of Change, and Group Treatment for Substance Abuse, a Stages of Change Therapy Manual, and self-help books called Changing for Good. He has been a wonderful addition to our trainings. We're so excited to have him, and we hope that you enjoy your evening with him.
Okay, turn this on.
Well, it's delightful to be here in person and virtually somewhere in the Ethernet, somewhere in the internet over there. So tonight I just wanted to kind of talk with you about kind of this process perspective that we have and how the stages and mechanisms and moderators of behavior change impact the journey of change in general, and especially the journey of change in addiction that we're going to be there. So the Transtheoretical Model has made, I think, both theoretical and practical contributions to advance our understanding of intentional change. Today, we're going to explore some of those key dimensions. And I want to dedicate this talk to Jim Prochaska. Jim is my mentor, inspiration, and co-creator of the model. He died just this past July 9th, of a heart attack. So we will be celebrating his life at the end of September in California. So I've been in this work for 40 plus years, so we're not going to go there. But over those years, you really see that there's been a lot of changes. There's been advances in our understanding of the process involved in addiction and in health promotion. There are lots of current scientific and clinical searches now for looking at mechanisms. So trying to identify mechanisms of change. So not just why people change, but how people change. And that's really where the model focuses as well. We also have seen that there's been some shifts in our understanding of the role of interventions and treatment. And that's both prevention and treatment. And we'll talk a little bit about that. Intentional change is self-guided change that can be influenced by interventions in context. So that's really the thesis underneath some of the Transtheoretical Model stuff that we talk about. So it was over 40 years ago that I began this journey in terms of what people did to be successful. Jim had been working on a trans-theoretical perspective in terms of clinical psychology. And the dilemmas that faced that particular work in terms of looking at systems of psychotherapy, and also what I did in my dissertation was looking at how do different treatments, many different treatments, do better than waitlist control. So if you ask people to wait, they wait, and they don't change. But basically, the treatments, even treatments that are very different philosophically, have very similar outcomes. The most telling one that I kind of found as I was kind of going through grad school is the Temple study, where they did 6 months of treatment, psychodynamic and behavior treatment, and a wait list for 6 months. And you look at those and, they were battling. There was all kinds of things between behavior therapy and psychodynamic therapy. They didn't like each other, and there was a lot of controversy about that. But basically, when they came to the end of it, they were treating people with anxiety and depression. Both treatments ended up with equal kinds of outcomes. And the other thing that was really striking was a lot of things that people said. They said, well, what was most helpful? People said things that didn't seem reasonable. It was kind of like, oh, the warmth of the psychodynamic therapist. It's kind of like, well, they're supposed to be blank slates. Where's this warmth stuff come from, or whatever? So again, some of the mechanisms seem to either not be, or there were multiple mechanisms that led people to the same place. The other is there were, at that point, 250, 300 different therapies. There were all kinds of therapies coming out. I mean, there was colon therapy. Don't ask, we don't want to go there. But basically they had that. And so there was all kinds of therapies popping up, primal screen therapy, all of these different kinds of ways and that were being kind of promoted across the country. So the issue was, well, wait a minute, can there be 250 different ways to change? Or are there some common elements and specific mechanisms that might be underlying it? And that's what Jim was working on. And I was in one of the first classes that he was doing that analysis, and the students were helping kind of review some of these therapies. The other thing that really happened at this was that many smokers successfully quit on their own. So when I did my dissertation, I had one group of people who quit on their own. Because if you're thinking about process, and if the process is the same for different kinds of therapies, it also should be the same for people who quit on their own. So right after we finished that, NCI said, we're really interested in people who quit on their own. So we said, well, we have some data about that. And so we went in and we had, ultimately it was 9 years of NCI funding. I was in Houston, Texas, and Jim was in Rhode Island, and we did collaborative kind of work across both of those with samples from the 2 different ones. And, you know, as you do with grants, we argued that that was really good because it was diversity and we could kind of do all of the stuff there. So we sold it that it was good to have 2 different places. So the transtheoretical model is this. I mean, if we think about the model, the stages of change is the thing that's probably the most known and asked about in tests and other kinds of things. Psychologists come up and go, you know, I've had to do your stages of change in my EPP exam. I go, okay, I'm sorry, but that, I mean, it's what it is. What can I tell you? So the stages are, and we're going to go through those, but the stages are only the one part. The processes or the mechanisms are the second part that's really important. And it's the interaction of the stages and the processes that are really at the heart of the transtheoretical model. It also is true that we've added a couple of things as we went along. When we understood our first research was on smoking, you kind of go, okay, well, wait a minute. Smoking, oh, it only works for smoking. Yeah, well, no, really, the context of change, there's a lot of other behavior changes that happen. So the context is important because when you're changing one behavior, the context that you're in is going to affect that particular, the stage movement, and it's going to affect the process activity. And then finally, at that time, there was a lot of work being done looking at decision-making. And so we took Janice and Mann's stuff and we brought in decision-making as a marker, especially a marker of in the contemplation early stages, the decision-making process was really critical. And Bandura had just been writing about self-efficacy. And so we kind of brought that in and said, okay, that's got to be critical, but self-efficacy is most critical in more of the action stages. So these are markers of early stage transition and later stage transition as we kind of saw it. So if you think about the tenets, all change is self-change. Okay, that's one of them. The personal process is more important than the treatment or type of treatment for intentional change. There's a variety of processes that are gleaned from different theories of therapy, hence the name transtheoretical. And if you bring those together, we believed you could make a little more integrated, eclectic approach. And that's what we were trying to do. And then a focus on the process can help providers with motivational and behavior change challenges and tasks across many different kinds of problems. So we started with tobacco, but that was not the end of it. It really moved into really health behavior change, and I'll show you that in a minute. Because you know, there's a lot of things we can do for health behaviors, right? We can for the health of the people. So we can put fluoride in the water, and that's a systems change that tries to help in terms of protecting health. We can ban certain substances or ban certain kinds of things. Doesn't always work with drugs, but we can ban things and do that. So there are system approaches to change, but essentially, if you're thinking about health promotion and disease prevention, especially these days, we know that a lot of that is related to the person's behavior. And that if you're going to go there, you have to do behavior change to get there. And that's true if you're in cancer, health promotion, safety, health protection, substance use. It's true that you have to either start a new behavior, stop a problematic behavior, or replace a problematic, or modify a behavior. And all 3 of those are 3 different patterns of change, but the model seems to work similarly for all 3 types of or patterns of change. And if you kind of start thinking about it, it's really kind of, this is where we want really people to be, right? In this zone, we call it the healthy lifestyle zone. It's moderated, self-regulated behavior patterns. That's what we really want people to do. And that's true with substances, and it's true with activities and whatever. You know, yes, you can do physical activity, but there is such a thing as exercising too much. And so if we go to excess, we should be getting feedback, and the feedback tells us to move back into the moderated self-regulated part. And this isn't new. The Romans knew it. In medio stat virtus. In the middle is where virtue is. Okay, that's what they said. And then there's also times when we have absence of behaviors like physical activity that we need to kind of move up and get into a self-regulated good behavior pattern, right? Now you don't want to do what some anorexics do, right? Which is they move from the absence of physical activity and they move all the way up through excess. And it's kind of like, oh, well, you know, if I think maybe I could really attain my body, my ideal body image if I could exercise 5 hours a day, and as well as not eat much and do those kind of things. So they go to excess, and you want to try and actually have to bring them back down either to kind of moderate. If we believe that, as with some substances, and especially something with the opioid crisis, that the person in excess is kind of stuck there and really can't move back to moderated self-regulated behavior pattern, then we tell them you need to abstain from this. You can't do this because you can't moderate what you're doing with this particular behavior. So that really gives you kind of an idea about what's the mechanism behind that. And the transtheoretical model has been studied with all kinds of behaviors like these. So initiating health behaviors, it's been used in screenings, it's been used in physical activity, sleep hygiene, stress management, condom use, pro-social networks. And it's called a heuristic model. We didn't create a theory. We created a model. And the difference between a model and a theory is the theory tries to explain everything. The model simply tries to give us, you know, like the double helix. It tries to give you a picture of kind of what is there and some of the ways that these things connect, so you can kind of explore them and figure out what's going on. And so in each of these areas, we keep learning stuff. So in condom use, for example, you know, people are sometimes in different stages for different partners. So with where they are in terms of using condoms with a casual partner is different from where they are with a regular partner or a committed partner. So we keep learning about the process, modifying behavior. So all of dietary kinds of things really are about modification. Drinking alcohol in moderation is about modification. Drinking and driving and making sure you're not driving when you've had some alcohol is about modification. And then cessation of health defeating or undesirable behaviors. So tobacco use, illicit substance use, abstinence from alcohol, domestic violence. It's been used both with the perpetrators as well as the victims to kind of understand their process of change in terms of stopping abusing, but also how do I manage the abuse? And so it's been used in all of those situations. So what the bottom line is, if you really look at desired healthcare behaviors, they're multiple, they're multidimensional, they vary in frequency, they vary in intensity, and they require different levels of motivation and commitment. It's interesting, sometimes I say, you know, oh, I love colonoscopy. No, nobody loves colonoscopy. But colonoscopy is high in intensity, low in frequency. So yes, you have to do it every few years, actually 10 years if you're clear and you don't have any trouble, but it's a relatively intense thing that you have to do. So that, I think, means that we have to begin thinking about the burden of change and understanding the change burden. And that became very clear in a public health project we were working on with maintenance painters. So people who would go up on those towers and do the painting and do that kind of stuff, and quitting smoking. So we tried to do that with we got one of the unions to kind of work with us to try and get these painters to quit smoking. But the union said, no, you can't, we're not going to, you can't blame the victims here. you've got to be careful because, you know, a lot of this is smoking hurts the lungs, but so does all the other stuff that these people are breathing in. So you got to get the contractors involved. And then we began learning, okay, so our project became clean air, clean lungs. And the goals were helping people quit smoking, proper ventilation, and respirator use. But when I actually looked at the respirator use, you know, people climbing up those things would have to carry big, heavy backpacks with the oxygen and have these masks on and trying to paint. And most of them said, there's just no way we can do that. We have to find another, you have to design another, the burden was too great. And so sometimes we have to change the design of the product that we're trying to sell rather than kind of trying to get people to do something where the burden is too high. And that's just a thought. So all of these behaviors can be integrated into the lifestyle to varying degrees. Here we're also talking about mental health because mental health requires some behavior changes, not only in terms of coping activities, but also in terms of medication adherence and all of the other kinds of things. So this often happens with people. This is a doctor kind of talking to a patient after a general physical. The best way to achieve good health, take care of yourself. Your lifestyle is destroying you. Change your eating habits, stop smoking and drinking, start an exercise program, get plenty of rest, learn how to handle stress. And of course, patients always kind of agree with the doctors and say, yeah, of course, yes, doctor, you're right. And then walk out. And this one says, I got to find another doctor. So free and unrealistic advice often changes or shifts the target of the change. You know, it's the messenger. So a lot of times you avoid the messenger instead of taking in the message. So we have to be careful about that. In the book that I did on addiction and change, what was really interesting is we looked at the process of becoming addicted. So how do people move through this top part here, the pre-contemplation? And actually initiation is a process of change. So how do people become having substance use disorders? Is they move through the stages of change. And then when they're all here in the dependence area and well-maintained change, they move into pre-contemplation for recovery. And so you can kind of think about that. And what's interesting is we've been looking at processes, contexts, and markers of change are relevant in both journeys, the journey into and the journey out of substance dependence. So if you think about it, they advance through stages of initiation. They move from thinking about doing it to experimenting, to developing a pattern of behavior that becomes habitual and consistent over time. So all of us, many of us have actually developed patterns of behavior of use of some of these substances, right? So some of us drink socially. So you've initiated and you've become a drinker to some degree, okay? So many of these patterns are normative and socially acceptable, so they don't create problems. So they're not, they don't meet the criteria for SUD. So addiction, when we talk about an addiction or a moderate to severe substance use disorder, we're talking about a well-maintained problematic pattern of engagement that's in this particular behavior. And it can be a problematic engagement in multiple substances, not just one substance. So once this is a well-maintained behavior, we move from prevention to recovery. So that's what's really important here. So if you think about prevention, I need to understand that all prevention messages aren't harmless. Okay. And the messages that I want to give to some of the kids who are still in pre-contemplation and maybe in initial parts of pre-contemplation, I want to get them messages that actually help keep them in those stages, right? As a matter of fact, what is our drug education programs about? Drug education programs are about bringing kids into contemplation. So we want you to think about drugs and think about them negatively so that you will be in pre-contemplation by design and not in pre-contemplation by default. Because basically that's what you're trying to do. But if you give some of those same messages to kids who are down here, who have done experimentation and who are now in the preparation and early action stages, some of those messages don't resonate at all. Because basically, you say, oh, well, drugs kill. If you use this, if you take this drug, you're going to die. And those kids know people who have taken those drugs. So they say, this person doesn't have the clue what they're talking about. Because I have a whole bunch of people over here, they've taken those drugs and they're not dead. So you have to give different messages, and you have to target the messages to where the kids are and what the goal is. Because we actually, in prevention, want to move people back. We want people to be in pre-contemplation by decision. That's really where we want to be in terms of using harmful substances. And that's down here. We need to really, when you get down into action maintenance, you really have got to give different messages, and you got to give support, and you've got to start working into recovery. Okay? And that's important because I think a lot of times adolescents who use substances are treated as though they need the recovery messages when they may need more prevention messages. And that's critical. So why is this maintenance so difficult? Why is this such a well-maintained behavior? Well, there's some mechanisms, especially critical. I mean, I think it happens in a lot of different problematic behaviors, but it's especially true in substance use. That basically there's a set of mechanisms that mark this end state of addiction, and that can contribute to the severity and the difficulty in changing. And those are neurobiological adaptation. The brain changes. When you do frequent exposure of these substances, it changes the way the brain functions. Okay? That's true for nicotine. We all have nicotine receptors in our brain. Okay? And actually, when you're eating broccoli, you're stimulating some of the nicotine receptors in the brain. Okay? But when you start bringing nicotine into your system at the levels that smoking does, you're actually flooding those nicotine receptors, and the brain adapts. It creates new receptors. And then when you go into withdrawal and you take the substance away, those receptors take a while to readapt. The brain takes a while to readapt. So neurobiological adaptation is one of the key elements that's why people call it a brain disease. NIDA calls it a brain disease. There's also reduced or impaired self-regulation. Not only is self-regulation problematic oftentimes for people who get into these before they even get into the substances, but after the substances undermine self-regulation. They undermine the executive functioning. They undermine emotional regulation. And so basically you have this compromised self-regulation, despite consequences, is one of the hallmarks of addiction, and why people call this a behavioral control disease or a behavior disease. Okay. And then finally, there's this salience or narrowing of the behavioral repertoire. The substances really have, using more and more of those substances, the people get concentrated more and more on that as the key element in their life. So when we talk about salience, how important is it for the person? And the narrowing of the behavioral repertoire. Things that were reinforcing before become less reinforcing. Activities become less reinforcing. And this becomes a prepotent reinforcer for that particular individual. And so it becomes integrated into their lives. I mean, they're willing to do all kinds of things to get this. So those three mechanisms, I think, are really important ones for us to remember why it's so difficult to get away and get out of addictions. And what's the characteristics of the well-maintained behavior that we call substance use disorders. SAMHSA recently, kind of a while back actually, talked about its view of recovery. So when you get there, where do you go after you've been in this well-maintained behavior? Well, Sampson says there's a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. It's not just about quitting drugs or drinking, okay? And recovery needs to be built on evidence-based clinical treatments and recovery support services for all these public people. So it's not about putting a Band-Aid or just stopping substance use or even just going to treatment. We know lots of people have gone to treatment that haven't changed or have changed for brief periods of time and then didn't. So again, it's kind of this process of change perspective is really important. So I'm going to give you a little bit of ideas about some of the evidence that we have kind of that seems to be mounting for a personal process of change. Okay? There's growing evidence that there's a constellation of client process variables, what the client does, that have the greatest impact and potential to be mechanisms of change. Now, when you see here mechanisms of change, lots of people are looking for mechanisms of change, but where are they looking? Most of the time, they're looking in, I think I need to go back. Yeah, they're looking in, we're looking at ourselves, right? That's who we look at most. We look at the therapeutic relationship. We look at the type of therapy you're doing. We look at the manual and the manualized treatment that you're doing. And everybody's looking there for the mechanisms of change. But the mechanisms of change are in the individual. And that's why this is critical to understand. So these change processes are related to particular change. They're involved in all change that occurs. So when I said we started with self-change, we followed for the first 2 or 3 years of our research, we just followed smokers without doing any intervention before we did an intervention, looking at the natural change process and the natural quitting process. It's not always very effective. It's not always very efficient, but it goes on. People kind of quit. Estimates are that maybe 6% of smokers every year quit, just as natural 6 to 7% of them. So we know that. We also know that changes occur with and without the active ingredients of formal treatment. People change on their own without us. I know it's hard to believe, or it's kind of like, okay, why would you do that without us? Don't you need us? No, they don't. Actually, there's self-change, there's mutual help, there's placebo. Placebo works pretty well in some cases. It involves client coping behaviors. It involves what the client's doing, and it interacts with the contextual variables over time. Sometimes these contextual variables help promote change. Sometimes these contextual variables hinder change. And we need to think about that. The other variables, patient intention and motivation. In Project Match, which was a large multi-site study of alcohol treatment, we worked with 3 different treatments and whatever. Pre-treatment motivation was the best predictor of outcome 6 months later and 12 months later. And actually, in that one cohort of people that we followed for 3 years, pre-treatment motivation was a predictor of abstinence 3 years later. Okay, which is disappointing since we think, okay, well, with all the treatment, we changed all that motivation, right? But what we bring into the treatment that often is key. I mean, I used to love, when I ran an alcoholism treatment center, I used to love the patients who I said, well, when did you have your last drink? Say, well, before I called you. I go, great. Because basically, I'm going to get credit for this, but you did all the work before you even came in to see me. So I'll sustain you and help you and do that kind of stuff, but it's my fantasy that I did it. So you have this natural or unaided self-change. Originally, people called it, early in the 70s, people were calling it spontaneous recovery. Well, there's nothing really spontaneous about it. They had to do hard work. They worked to change, and there was the same kinds of issues, support mechanisms, decision-making, commitment, self-reevaluation, behavioral coping. They used all of those things when they were interviewed and talked about this. So self-change wasn't just spontaneous, it just happened. And then placebo responding. We give people stuff that is inert and they change. And Tor Wager, who's done some really interesting work out at the University of Colorado, has done some work to show that placebos change the brain. So it's not just people kind of saying, okay, well, I'm going to change because I feel like I'm getting this drug. It actually affects their brain chemistries as well. So placebos are very important, and we've kind of we try to X them out of the equation, but we really need to understand them probably a little bit more. The other issue is the importance of patient behavior during treatment. So it's really the patient's, we know, for example, that staying in treatment is a good, dosage, we talk about dosage. Dosage predicts better outcomes. Why? Well, because the person stayed in and they allowed you to work with them. Commitment language, some of the motivational interviewing stuff, patient to therapist talk ratio, Terry Moyers's work and whatever. The talk ratio, if the patient talks more than the therapist, actually the outcomes are better. So setting a date for change. We did that in terms of implementation. You set a date. So we used to tell the docs when we were training them to do tobacco interventions, your job, motivate, set a date. If the person set a date in the office when they were visiting you, the probability was 3 or 4 times greater that they would actually make a change attempt to quit smoking. So that's implemented. And the implementation model is also one that we use, but intention is a critical element of the implementation model. Patient evaluations of their own strengths and vulnerability. So temptation and craving have been predictive of outcome. Higher temptation, worse outcomes. We created a self-efficacy measure and a temptation measure. The self-efficacy also predicts. And actually what we did was we created a measure of level of temptation across 20 situations compared to confidence to abstain across those same 20 situations. When you compare the level of temptation and confidence, it actually predicts relapse. So the lower the temptation, the higher the temptation and the lower the confidence predicts relapse. The opposite predicts abstinence. And I'll show you some data about that in a minute. And then change talk, acknowledgement of consequences, people talking about those things, that really helps. And then finally, we know that there's certain kinds of interventions. We do brief interventions. We teach brief interventions. Well, the brief intervention is brief. So what's the mechanism? Well, it obviously activated the patient's process and the outcome then happens after that. But again, it's not the brief intervention as much as the activation of the patient process that's really critical. And there are also developmental periods where change happens. So, luckily, I know we're across the street from the hallowed West Virginia stadium, where there has been rumors of excessive drinking. I don't know. Somebody once said that. I don't know if that's really true or not. But with college, and there is excessive drinking among a lot of college students. Okay. Luckily, that doesn't continue. It's a time limited kind of thing around college. And when they get out, when they get jobs, and when they start doing some other kinds of things, they don't drink as bad. Now, that's not all of them. Some of them continue to drink that way. And we have some adults who also do that. But marriage, pregnancy, people change when you kind of have a pregnancy in the family. So those things trigger change and activate some of the change process for individuals. And then the success profiles that I'm going to show you at the end of treatment. This is a quick test of what you will do. So you probably were busy over the weekend and the weather was bad and all that kind of stuff, but you didn't see that there's a large research study from the NCI, multiple site study that looked at and said, watching television more than 1 to 2 hours a week causes brain cancer. So the question is, how many of you would stop watching television more than 1 to 2 hours a week on the result of that? One, meh, little, maybe. It depends on what? Oh, it depends on what's on. Okay, there you are, that's it. So why would you do that? Okay. You got it. Okay. So he doesn't watch, he doesn't have to change much. Ah, okay. We may have some exceptions. Okay. So what are the rest of you doing? Watching TV? Okay, somebody's watching TV. Well, what are you thinking? How do you react to that? You're still deciding? Deciding about what? Is this about the study or about the change? Okay, more evidence. That's a good one. Yeah, let's look at the primary source. We got those, those public health people. They tell us a lot of stuff about what we're not supposed to do and all these studies and whatever. I mean, how could we ever trust them? I don't know. Other people? What would you do if you were entrepreneurial and had this information? Try to prevent it, right? So what would you do? Somebody, trust me, you would have a TV ad for the shield that you could put in front of your TV that would block all the rays and stop that. Or somebody said, I'm going to create the helmet, that you wear the helmet, put the helmet on, and you can watch TV to your heart's content, and without it will block all the brain damage that's there. So this isn't a real study, as you probably know, but basically people don't just jump into change. People want to, what would I have to do if this really were true to get you to change? Well, I would have to get you to become interested and concerned about TV use and its connection to brain cancer. And I would have to get you excited to some degree about that, or really concerned about that. I would talk to you about brain cancer. I mean, have you ever seen somebody, he doesn't really want, somebody dying of brain cancer? It's not pretty. They have to become then, after they're concerned, they have to become convinced that this is in their best interest. Because again, most of us with our health behaviors kind of, we do a little bargaining in terms of some of that. You go, okay, well, yeah, but what about, one guy said, I'm going to stand on the around the corner from the TV and then only look when it's really interesting stuff going on. Okay, and then the younger folks in the audience usually go, well, what about streaming? If I stream it on my computer, is that the same as the TV? So everybody tries to kind of figure ways around change rather than going at change a lot of times. And then finally, once I'm convinced that this is in my best interest, I still have to do a plan of action and get committed. It's great that you guys have joined the gym, but until you go, you're not in action. That's preparation. You've got to do that. And so you got to get the action, but then you get committed, and then you got to take the actions to do it. Okay. I know what you have to do. You'd have to get rid of some of your TVs or something like that, or there's a TV in every room. So that's what I would have to do. That's the process of intentional behavior change. Okay. And that's what the stages are about. So the stages really, there's labels and tasks. The labels are less important. They're important because I think they're non-stigmatizing. So somebody is not a resistant, no good person. They're just in pre-contemplation. And the, contemplation is considering, preparation is preparing, action is you're taking the initial change, maintenance, you're sustaining change over time. But the key is really the tasks. So if I'm going to work with you where you are in this process of change, I need to focus on helping you get the tasks and complete the tasks in a way that's good. Stages are not boxes. I tell people don't use pre-contemplator. It just sounds too stable. And if you do a good motivational interview, people move from pre-contemplation to contemplation in 20 minutes. You can see it. Okay. Now, it may not mean they move on further, but they start thinking about it seriously if you do a good motivational interviewing intervention. So it's a logical sequence of tasks, but it's not followed logically in the sequence because there's regression, there's getting stuck, there's recycling. I'll talk about that. It's also behavior and goal specific. And that's really important because sometimes people have different goals and they're in action for their goal, but in pre-contemplation for your goals. So a lot of times we find that with abstinence, you know, the program promotes only abstinence. Some of the clients go, I'm not going to buy abstinence. I'm just going to do reduction. And I'm in action for reduction, but in pre-contemplation for abstinence. So it's goal specific. It's not always a rational or completely conscious process. There's a lot of stuff under the surface in terms of implicit attitudes and motivation and latent motivation that we have there. And then it involves values, emotional reactions, and many important experiences. So these aren't simple things. The idea is if I know where you are, then what's my task? My task is to help you by help you raising doubts. So I need to talk to you about brain cancer and TV watching and all of those kind of things. It's to help you voice reasons for change. So tell me, have you ever seen anybody dying of brain cancer? Now talk to me about that. What did that look like? What did it seem like to you? And I would have to get you activate some of the value systems and the ideas that you have. And in preparing for change, I'd have to get you to build a plan. And I always say the plan has got to be effective, but it's also got to be acceptable and accessible. And you need all three of those in the plan because we have a lot of good, effective plans. A lot of our therapies are filled with plans of how you can do this. And they're good, they're effective. If you do them, they are effective. But if they're not acceptable to the person, they don't get done. We were talking about mindfulness earlier, but relaxation was one of those things where, you know, my graduate students, I get them to kind of do relaxation because we want to do that. Say, oh yeah, okay, I'm going to do this with this anxious patient. So they do the relaxation and the person says, I've never been this relaxed in my whole life. This has been great. And then they say, okay, well, do this twice a day over the next week and then come back and see where you are. And then they come back and I didn't get a chance to do it as often as you suggested. Well, how often did you actually do it? Well, I think I did it once. Okay, and so the therapist thinks, okay, the student therapist, I didn't do it well enough. I need to kind of help them do that. And so after 2 or 3 times like this and a couple of weeks where they don't do it, you kind of go, well, they're not doing it. What am I doing wrong? I'm going, you're not doing anything wrong. You're just not motivated to do it. So even though they're very relaxed in the session, it doesn't carry forward for some of them to do it on their own. And so you need to do that, but that doesn't seem to be happening in some of the mindfulness work that's being done here. So that's actually interesting. And then initial change. And you make the change, you got to implement the change, you got to overcome the early obstacles to change. And most of our plans aren't perfect. So one of the things that's important in action is revising the plan. Because what happens when the plan isn't working? What most people do is throw out the change instead of revising the plan. So it's like, oh, this isn't working, so I'm done. I'll try now. Maybe I have to do it over the summer. When school starts again, that's when I'll do it because it's too hard to do it. Okay, I'm going to quickly run through this second piece here, which is the processes of change. So the the processes of change are change engines. The key mechanisms of change that help you, and it looks like it's doing the right thing at the right time. So we need cognitive experiential processing early in the stages to kind of get through the pre-action stages. We need behavioral processing in the preparation, action, and maintenance stages. And the use and the emphasis may differ by pattern. So, for example, when we see the people who quit smoking, a lot of times they really want to move on, and they don't use self-reevaluation and some consciousness raising and other kind of stuff once they've quit. But if you're doing a behavior like dietary change, you may need to keep some of the cognitive experiential processes going to kind of keep you convinced that this is really helpful and you want to do it. So it depends on whether you're starting, stopping, or modifying a behavior as to how important these are at different points along the way. And what we found in the research, actually, Jim had kind of put together 5 processes at 2 levels in his original book. But basically, when we did the research on them and tried to kind of find these processes, which I tried to do in my dissertation, and we tried to do in some of our early work, that it came out that there were 5 different types of processes in 2 different categories: cognitive experiential and behavioral processes. And if you look at, this is the first in terms of factor analysis. So you have the basic factor analysis, second order factor analysis, and then they are correlated. So you have a third order factor analysis called processes. And again, they're from different theories of systems. So here are the key processes in experiential: consciousness raising, emotional arousal, self-reevaluation, environmental reevaluation. It's changing the way we see ourselves. It's getting more information. It's getting some emotion involved in this process of change. And then some of the societal kinds of realizations. So self-reevaluation is, if we just look at some of these, self-reevaluation involves evaluating information, experiences, and personal values. Okay. It happens in the space where I live. So it's really important, especially for self-reevaluation, environmental reevaluation, to know culture and to be culturally sensitive, to kind of understand where people are. Environmental reevaluation is very similar to self-reevaluation, except the focus is on the larger context. How does my behavior affect other people? And how will my change affect other people? We have a lot of, if you really look at the TV and look at advertising and some of the media stuff, you'll see a lot of appeals to try and activate self-reevaluation, environmental reevaluation. I mean, people are jumping into swimming pools with psoriasis after they take this medication because they don't have the psoriasis doesn't look at it. So what did all that stuff doing? It's all trying to get you to change the way you think about this particular medication and see the benefits in your life, personally and in the environment for doing that. Usually there's kids around too to kind of help you kind of see how it is going to help you with kids. So a lot of our social messaging really does that. And, we have lots of messages about global warming. The tobacco companies are lying to you. Do this for your children's future. Your marriage is going to be better if you do this. So those are the evaluation processes that you look at. The emotional arousal stuff is also really important. So we need to bring, if you look at the therapies that focused on emotional arousal, Fritz Perls and Gestalt therapy, dialectic behavior therapy. Marcia Linehan has done some really interesting stuff trying to incorporate emotion regulation into the therapy with especially dysregulated borderline and other kinds of diagnoses. So emotions are also involved in reevaluation, but this is more of a direct experience of emotion. And I get appeals all the time. I did donate to some people, and as soon as you do that, everybody gets your name off of one list or another. And so my mailbox is full of little things coming in that say, this is the last time you can do this. This is it, triple your contribution, whatever it is. But most of them also are appealing pictures of starving children, animals being mistreated, glaciers melting. What are they supposed to do? It's supposed to arouse emotion so that you will move toward deciding to take action and do them. So that's why it's important in there. And some theories believe actually that we're more influenced by our emotions. Pearls used to say, get out of your head and get into your gut. And that's what you have to do. Don't worry about the thinking. I don't want you to be thinking about this stuff. I want you feeling about it. So we have all of those. And then we have the behavioral. So behavioral self-liberation, choice and commitment, stimulus control and counter conditioning are behavioral mechanisms that we know work, especially in addictions. And then reinforcement management, Skinner's work, and then helping relationship, Rogers and his work. So you have all of these different kinds of activities that you're trying to do. So, with counter conditioning and stimulus control, we know that a lot of our behavior is conditioned, right? And especially drug behavior. I don't know how many of you ever smoked. I did. And basically there were lots of cues to smoke. Okay. If you have coffee, and people say, when I have coffee in the morning, I have to have a cigarette. People at the end of a meal had to go outside and get a cigarette in there. So there's a lot of cued behavior. So how do you handle cued behavior? You either teach people to change the cues or change the response. And that's what we're doing in a lot of our therapy. Most of the time we teach people to do relaxation. Why do we teach relaxation and mindfulness? So to have more relaxed addicts? No. We're trying to teach that so that they have an alternative response to the anxiety that used to be calmed by going to grab a cigarette or going to take a drink or going to use drugs to do that. So it's a counter conditioning kind of mechanism that you're using. And again, with Skinner and Rogers, you have other things. When I talk about helping relationships, I want to just highlight that it's not just having friends. Drug abusers have a lot of friends or colleagues or people that they know. It's really having somebody you can talk to about change. And that's why a lot of times therapists are the only people who are doing the helping relationship piece, because they're the only people who are really talking about the change piece with their clients. So how does that work with treatment? Well, if you think about treatment, this is the intervention over here, okay? The intervention is trying to activate some of these processes, and then the processes help the person achieve the task of the stage, okay? And you always have life context and environmental influences that are always out there also operating with the treatment. Again, you say with treatment, we used to say, okay, you have them 1 hour a week, okay? How many other hours are there in the week to influence their behavior? So think about that, but interventions can be helpful if they kind of activate these processes to kind of do that. Same with decision-making. Same thing happens. The intervention activates the change processes, which in turn help the individual meet the tasks. And that's true for behavioral stuff too. Taking successful action, you have the behavioral processes that you got to do. The interventions help people to do that. And then managing the challenges of the change and managing change. So the process activity is the province of the client. The intervention is what we do. And I like to say, we have treatment plans and change plans. The change plan is the client's. The treatment plan is yours. Treatment plan says what you're going to do. The change plan says what the client's going to do and how they're going to accomplish the tasks of the stages. Okay. So again, what we're trying to do is figure out how can I promote all of these kind of activities as people move through these stages of change. And again, they're not boxes. So it's not like, oh, I've got 1 foot in contemplation and 1 foot in pre-contemplation, and they're process variables, tasks. So it's getting enough of the concern. So what you're trying to do is find the kinds of activities that would help motivate, activate some of the experiential processes and some of the behavioral processes as you're helping people move through the process and move on the journey. Okay. Can you do this in group treatment? Well, we've tried. This is our group therapy manual. We have 15 kind of sessions that for pre-contemplation, contemplation, preparation, and then we have 15 or so for preparation, action, maintenance. And the only difference with this manual, the activities are similar to what a lot of programs do. The idea behind this, though, is every activity targets certain processes of change and tries to kind of say, okay, with this activity, we're trying to get self-reevaluation or more environmental reevaluation. And so the therapist goes in trying to see if that process happens. And you can see these processes in treatment. I don't have time to show you, but there's videotapes that you could see when you really listen and look at what the client's doing, you could see some of these processes active if you look at a therapy tape. So there's a clear difference between pre-action and action stages. And so the challenge is, what do I have to do to help people move through those so that they successfully transition into action? And then what do I have to do in the action stages to successfully sustain and maintain change? Okay, so the model gives you a template, okay? And again, that just helps you understand where issues are, motivation, decision-making, efficacy, and also where processes are. And the bottom part are the things that influence the process activity. And then this relapse and recycling I'm going to talk about in a minute. So this was a study that we did 9 years of research with the Project Match, multi-site study, lots of folks, Bill Miller, Dennis Donovan, a variety of people with sites all around the country. And we had 950 outpatients and 770 aftercare patients in this trial. Okay. And when you look at these, we tried to look at the end of treatment. The treatments didn't do very differently. People improved, but the treatments didn't make, all three treatments contributed to people improving. And we were trying to do matching. And most of the matches that we had didn't quite work. So what we did, Joe Carbonari and I did, was we kind of looked at, let's do some looking at these people from their outcomes. So people who during the 1 year follow-up period were completely abstinent, people who were moderate drinking, never having a binge episode, and people who were heavier drinkers. And so we had three groups and we said, okay, let's look at what they look like when they came into treatment and what they look like at the end of treatment, these three different groups. And what you see is that we had these different stage of change scales, temptation, abstinence, efficacy, processes of change. There was no difference across all of those variables by treatment. So all the treatments ended up with similar levels of activity, process activity, similar levels of efficacy across that. However, when you look at what did they look at like when they came in, what you see is here, the yellow line is the people who did the best, were abstinent. The red line are the people who did the worst, were heavier drinkers during the 1 year post-treatment. And the middle group was in the middle, the blue line. And what you'll see is this group looked different when they walked in the door. This is before any treatment, okay? The people who were successful looked different. They had more of a readiness profile, okay? So what happens? They have higher levels of action. They have high levels of struggling to maintain when they enter treatment. They have high confidence, higher confidence, and higher temptation. What happens during the course of treatment? This happens. That basically what gets accentuated is they now have really high action. They're lower in struggling to maintain. They have high confidence, low temptation, and they're using behavioral and experiential processes. And the middle group is in the middle. The red group, we shouldn't have let out of treatment because they weren't ready. So that's what we call the success profile. And the interesting thing was, this is the end of our 12 weeks of treatment in outpatient. Then if you look at these same variables, this is the end of treatment for aftercare. So people who had gone to inpatient treatment and then gone to an aftercare program. And what you'll see is the same profile, but it's very similar to the outpatient profile at the end of treatment. The successes are yellow, and they have the same variables, and the reds are in the opposite direction all the time. So it makes an argument for, I think, understanding that process is really important in terms of success. And this is what we look. Success, we want people to look like this. It looks like this. It's messy. There's multiple change attempts and whatever. So the other thing that the model contributed, I think, is really that when we thought about relapse and we thought about this process and we thought about recycling, that basically relapse wasn't a stage. Relapse is an event. It's something that happens, and then people go back through some of the earlier stages. Okay. So recycling is a reality. It's what in psychology we call successive approximation learning. Okay. This is a relapse curve. This was done in the 70s. All the people here on the 3 different substances were off at this time. This is what happens when you go out 12 months. 12 months, 1 year later, you have about 30%, 30 or 30 some percent success. People totally abstinent at the end of that 12-month period. And you'll see here, lots of people drop off very quickly and are not abstinent. In Project Match, we had the same kinds of things. We had lots of improvement in drinking. So this was the group, this was the outpatients, averaging about 28 to 30 drinks on an occasion before treatment. And this is after treatment. You'll see that they're about, we call this percent days abstinent. What's the percentage of days in the month that you're abstinent? And they're up to 90%, 80 or 90% abstinent days, where they were at 30% days abstinent when they came into treatment. So we know that there's a lot of relapse if you think about going back and it's not working. But relapse is not a problem of drug abuse. This is Tom McClellan's work. It's a problem of instigating and sustaining behavior change. Relapse happens across type 1 diabetes, hypertension, asthma. Relapse rates are high across all of those. So it's not a problem of drug abuse. Non-adherence. We have over 50% who start physical exercise are not doing it 6 months later. Okay. 2/3 of Americans have prescriptions. So that's 200 million people, right? But approximately 50% of them do not take their prescriptions as prescribed. That's 100 million people. So medication non-adherence leads to multiple deaths and a lot of healthcare dollars. So good. So I've been doing more work recently on relapse and trying to understand relapse and what it is. Relapse is really when a person gives up on change. We shouldn't be measuring it as about, well, did you relapse? You were going to go, your goal was to exercise 3 times a week. If you exercise twice a week, are you in relapse then? No, I think you're still in action, but you're not meeting your goal completely. So we need to think about that. It's not a total failure, but a learning opportunity. And that's where we are. It's best defined by the individual when they give up on the change process. If I give up on making this change at this particular time, then I'm in relapse. It's not about numbers of drinks or numbers of drugs used or number of times you used. So you have to try again to move successfully through the stages. So the role of recycling is actually to help people adequately accomplish the tasks of the stages and engage in the mechanisms that are needed for change. So this is just an illustration. You can move forward from pre-contemplation to contemplation with a little concern, a lot of concern, or a moderate amount of concern. And so a lot of people move forward in this journey, but they haven't really completed some of these well enough to support the later stages. And when people relapse, people would like to say, well, they met a cue they couldn't resist. It's not true. The problem could be in the contemplation stage. The problem could be in the pre-contemplation stage. It wasn't their interest and concern. It was really their parents who wanted them to quit. And so when they got down and getting to the hard parts and whatever, they didn't have enough interest and concern that turned into a good, solid decision that turned into lots of commitment to make it happen. Okay. And so people go back through this multiple times to get it right, to get enough to move it all the way through. So that's what this cycling is about, and has been, I think, a good thing that is helping to the providers, because a lot of times people, count coup in terms of what's our success rate? Okay, but you need to take into account that success rate is moderated by this cyclical process. Just a couple of final things. Relapse is not the opposite of recovery. Not trying is. And we have, even in psychology, we have error-free learning. Error-free learning is not as good as error-full learning. That people learn better if they make mistakes. And so trying to kind of help people to not ever make a mistake is not always the best way to teach people. So it's again, try again. But again, it's not just trying harder, it's trying smarter. It's doing the things that you need to do to get it happen. And I've been doing a lot of reading on failure, and failure is sometimes the only way to learn and progress. Okay. James Dyson, the guy with the rollerball kind of thing. Okay. He had created more than 5,000 prototypes before he got one that he could sell. Okay. Most scientific experiments fail. The vast majority. I mean, we always talk about the file drawer problem, which is they never get published. So you think, oh well, all these projects, this really is good. Well, no, there were about 20 of them that didn't work at all, and now we have one that got published that says it worked. So we need to kind of be careful with that. Matthew Syed has done some really interesting work. He talks about it's called black box thinking. And what he says is that basically we in healthcare don't take failure seriously. It's a cult. There's a culture. He calls it a culture of evasion. We kind of think about, it's an anomaly. It's unfortunate. Yes, the patient died, but the operation was a complete success. We're doing the best we could. We just happened. We can't really explain why it happened. Okay. But he said in the airline industry, they take failure seriously. They look at the black boxes, they examine everything, they interview the wife of the pilot, they interview the family, they look at the whole context of what was happening so that this wouldn't ever happen again, because that's what the key is. So, Eleanor Roosevelt said a long time ago, learn from the mistakes of others. You can't live long enough to make them all yourself. So what do we need to successfully do that? Persistent efforts, repeated attempts, learning from the past, overcoming habit and neuroadaptation, finding support for impaired self-regulation, begin building a new meaningful life, and never give up. I interviewed a pregnant, a woman who was postpartum. She was using heroin while she was pregnant, and had an exposed pregnancy with the baby. She went into treatment, and now she's a counselor and doing some work. And so I said, what would you say to other women? She goes, stick and stay. You'll be tempted to leave. You'll be tempted to not do it. Stick with it for a little bit and stay with the process. Keep working at it. And again, that's really the key element there. How can we do a better job in debriefing relapses by looking at all the process perspectives and trying to kind of figure out how did those go for this particular individual? Why did this happen? How did this happen? Blame gets in the way. Blame gets in the way of recycling. Blame gets in the way of doing that. And a lot of times it's programs and patients do this. If it wasn't successful, the patient said what? The program didn't work. And the program people say, oh, our program works. Okay, we have successes. You just didn't work the program. So everybody's arguing with one another. The problem is it's the process. Let's keep working on the process. Stigma is really important, and self-stigma is, people aren't proud of the fact that they've tried to kind of do this. They spent this money on treatment and they're not successful. They do self-stigma. It's worse sometimes than social stigma. And you need to have some self-compassion, mindfulness, common humanity, self-kindness, all different things that you could help people do to kind of do that. So why don't individuals get it right the first time? It's complicated. Recovery means building a new pattern of existence, really, of life. So again, the message from people in recovery is never, never give up, never stop trying. If one thing doesn't, and Ann Fletcher, actually, she has a book that she interviewed lots of people who have gone into recovery and either stayed in recovery or were unsuccessful in terms of recovery. And her, after kind of looking at the relapse stuff, instead of dwelling on past failures, it's more productive to learn from the past recovery attempts as a rich library of experiences to shape your future. This is my view of treatment. It's client process. Treatment is a mediator. You have client process that brings outcome. And that's how we do that. So I wanted to spend the last couple of minutes, we don't have many couple of minutes here, talking about interventions. Because again, we talked a little bit about that. Keith asked about kind of looking at some interventions, opt-in and opt-out interventions. So how does that interact with motivation? Because ask, advise, refer doesn't take motivation into account. It says ask, advise the patient, and refer them. And that's more like the opt-out. You tell the patient, I'm referring you to this person, and they have to kind of refuse. Okay. Most of our programs try to do opt-in and kind of say, okay, where are people? What can I get you to go to treatment? It looks like you've got a serious problem here. We have some resources. Do you want to go? And they'll say, no, not right now, or something like that. So the opt-out gets more people into treatment. But what I looked at was that basically there wasn't differences in outcomes, in the actual smoking outcomes. And we see that in our quit lines. So we have now electronic health referrals. I don't know if you have that here, but basically, if you have a smoker in front of you, you talk to the smoker, you try to motivate them, and you ask them, do you want me to send this up to I'll get somebody from the quit line to call you, and you click a button. I look at the data from that information from our quit line in Maryland. 50–60% of those people who are referred in the electronic health record never answer the phone when the quit line calls. So engagement rate is really bad a lot of times when you have that opt-in, and especially what I think is most helpful is you think about cold, warm, and hot handoffs. So cold handoff is, here's the quit line card. You call that number and they'll help you. Warm is kind of make sure you kind of connect them with the quit line, show them a video of the quit line, do something with that, try to get them encouraged to do it. Hot handoffs are walking down the hall and handing off this person to someone who will talk to them and try to motivate them about their quitting. So we have a lot of these things. And again, it doesn't mean that you shouldn't be giving advice. It doesn't mean you shouldn't be kind of moving people on and trying to kind of help them. It's just that what I find is that we use A3C: ask, advise, assess readiness, and then connect. That's what we've been using in our tobacco center. But there's a lot of things that you can do that can activate people to kind of go to treatment or to get into treatment or do those kind of things. But it's also very important to realize that part of it is that motivation, at least as far as I'm concerned. You can order people to treatment. We do that all the time. But a lot of times people will not, when you're trying to get change, they may go to the treatment, but not do the change. And you need to kind of have both of those things going at the same time and tailoring your messages to do that. The last thing I'm going to say is basically the process of change is larger than all of our treatment and intervention programs. And most people want to be this last intervention, because then if they're successful, they take credit. But the first treatment may have been the most important. The first treatment may have been the treatment that got them kind of started in this process and this cycling. So don't be myopic, build on the experiences of the past. Many treatment programs don't even ask you, what did you do in your last treatment program? Don't even ask you kind of how successful you were, how long you were successful, all of those kind of things. We're gonna help you now start from scratch. So be part of the larger picture and respect the entire change process. Change is complicated. You need both a Google Earth view, and you also need a GPS turn-by-turn view of the process. And so hopefully the model actually provides that global view, but also the turn-by-turn GPS part. And that GPS part, there's a lot of recalculating that goes on, recalculating. So if you're going to enter the client's change process, you need patience and persistence. You need optimism and realism. I think I like the perspective of a minor league coach. I coached my daughters playing soccer and when they were like 7. So, you know, that you have to have patience with that group. A butterfly can stop play and you got a lot of problems there. But the other piece that you really need as you're working in somebody else's change process is you need self-care, take care of yourselves, boundaries. You can't do it for them. And the more you try, the worse it is. And cultural humility. We don't know everything. We need to kind of understand the client's perspective to do that. Okay. Questions, comments, thoughts? For 1 or 2 more minutes, I'll do that. Any thoughts or questions that you have about the process or what we're talking about? Are there chat ones? Anybody have any questions? It was all totally clear. It's hard to do. Yeah, go ahead.
So I was remarking with some of my colleagues, some of us have the psychology, therapy, social work sort of background. We learned about the model when we were doing that. We learned about it in public health. And so we've seen a lot of application of it. One of the things that's on my mind a lot is, are there some types of human behaviors or health issues that have a harder time or are more resistant to the model, or that you need to, focus in on certain areas? I guess what I'm driving at is, a lot of what we see is, for addiction, alcohol or smoking cessation sort of models. Are there other things that where the model has been applied that maybe it has experienced challenges in more particular areas that we would need to pay attention to?
Good question. Well, again, some of the stuff I was talking about before, if the burden is too high, it's really hard for people to make the change. So sometimes we have to think about engineering and re-engineer the change that we're trying to kind of get in order to kind of get people to move through the process. Addictions are particularly struggling, and especially opiate addiction, because of the quick responsiveness of the body to the lack of the opiates. And so those make it really harder. And you know, I mean, in alcohol, we always do, well, you have to do detox. And so we detox people for 2 or 3 days, and they'd walk out and they'd start drinking again. And so detox should be a way to kind of get people in. And I don't know. I mean, I think we probably need, you need a balance between being overly aggressive and confrontive and being laissez-faire. If you think about motivational interviewing, Bill says, and Steve say, it's not, you know, there's ways to kind of deal with things. There's following the client, there's leading the client, and there's guiding the client. Motivational interviewing guides. And so I do think we have to have a way to kind of think about that and understand that. So some of the behaviors, the harder the behavior is to kind of sustain and maintain, I think the harder it is. But again, you have people doing marathons. So that's a hard behavior to do and continue. And then you get people doing multiple marathons. So I think that you know, each change brings its own challenge. Does that help? Yeah. Is there another one?
So we have a, oh, it's on. Okay. So we have an online question here. Oh, that's several lines. So you
Okay.
gave an example in using the TTM to initiate, quote unquote, initiate pre-contemplation about drug use and never using youth, and to take them through the stages in order to not capitalize to begin using drugs, leading to enhanced decision and maintenance of continued non-use. My concern here is that environmental influences, for example, role models, peers, poor community infrastructure, negative community norms, limited opportunities for pro-social behavioral development are stacked against so many rural youth, such as in many communities of West Virginia. Now we're getting to the question.
Okay.
My question in this context, therefore, is to ask you to give an example of how to work with the TTM to initiate, quote unquote, pre-contemplation about not using drugs among rural youth and communities where the environmental cards are so unevenly stacked against them.
Wow. Okay. That's a simple question. No, I think you're entirely right. I think that the challenge is there is a lot of influences around. There are a lot of influences around. There's a lot of things on, I mean, people are doing crazy things just by watching it on TikTok and doing those kind of things. So there's a lot of influences that are attracting and trying to attract youth to engage in certain behaviors. So what I would say is, how do you do that? I think one is you really kind of focus on helping them see the important value that there is in not using. That's one thing. We did Maryland, we actually looked at stages of youth in the youth behavior risk survey, and tried to kind of help understand where people were in pre-contemplation, contemplation, preparation, where these kids were. And we defined it by kind of people saying, you know, people pre-contemplation is people saying, kids saying, I don't use and I'm positive, definite that I won't use in the next year. So you're trying to kind of get them to kind of make a kind of a commitment to not engage in this behavior. But again, you know, you have to kind of think about the environment and the context. So if context is giving them no other alternatives or not giving them ways to kind of satisfy themselves in terms of kind of feeling good about themselves and not having to hang out with some of these other folks who are using some of these other substances. I think you have to kind of create alternative things. So, you know, I mean, for a lot of kids, it's sports. Or it's some other kinds of activities or band, or the more you can get them engaged in some of the things that happen in the schools, some of the things that happen, you know, my brother went to a boys club and start working out at the boys club or whatever. And kind of that seemed to really help him kind of focus on and in some achievement oriented kind of focus. So I do think it's challenging. Resources and lack of resources is critical in terms of both engaging people and saying, okay, what the hell? If you feel like there's nothing, there's no there, why are you going to kind of not take this risk? But the other thing is, I think we need to be thinking about where it's just not in pre-contemplation, but we need all along the path, we need to be presenting barriers. So I think it's probably almost impossible to stop some kids from experimenting. But stopping the transition from experimentation to use is, I think, a critical piece. And stopping the thing, finding out initial use and stopping it from becoming more severe use. And some of that involves family. I mean, I do think family, we know monitoring, for example, and that's something that doesn't always happen in some of the poorer families because the parents are working. But if you think about the monitoring helps interfere with the process of initiation. So, you know, my daughter was having trouble in school and was hanging out with some of these folks who were drug abusers and were beginning to use substances and whatever. And so she started kind of fooling around with some substances and whatever until my wife found a pipe in her drawer. And she said, oh, we were smoking cigarettes. I go, you know, I'm a substance abuse researcher. People don't smoke cigarettes using a pipe. Okay, this is not cigarettes. This is marijuana. So don't give me that stuff. Now, of course, marijuana is legal, but so you know, we said you can't. You're grounded for a couple of weeks, and I'm going to do drug testing. So pee on the stick. We'll find out if, you know, when everything is clear for a while, then you can have your privileges back. So you need a combination of both kind of monitoring and intervening at various points along the way to keep people safe and keep kids from moving way into there. But I'm not sure you can stop the experimentation. Is there another or?
I have another one online. It says, from an anonymous attendee, what methods do you find most helpful to assist patients in discovering their intrinsic motivation?
I think asking patients about their hopes and dreams, asking patients, you know, there's no high school yearbook that has underneath it, my desire is to be in jail twice, have 2 failed marriages, and to become a substance use disorder person. So everybody had some hopes. And so really start where they are in terms of their hopes and dreams and where they are today. Start with what is important to them. And that's how you can kind of bring out the motivation. And again, some of the motivation interviewing tapes, if you look at some of Bill Miller's and Terry Moyer's tapes, they really do a wonderful job of kind of going in and working with the person to try and get to their value system and to their key issues. Well, thank you. You've all been very good, and we've gone over time, so I'm sorry, but hopefully it was helpful. Take care. Thank you. And I'm still here if you have some questions and want to talk about it, but didn't want to say it in front of everybody else. Okay. And I think
There are refreshments